Hello, dear colleagues. On behalf of the Nephrocritical Care Society, I extend my warmest welcome to each one of you to this special edition of Straight Talk. Today, we are honored to have with us a very special guest, Professor Dr. Claudio Ronco from Italy, a figure who requires no further introduction. Professor Dr. Ronco is globally acclaimed and respected for his groundbreaking research and contribution to the field of nephrocritical care. I recently had the privilege of meeting him at the AKI CRRT conference in Hyderabad, India, and it's a pleasure to welcome him to our show today. Warm welcome, Professor Dr. Ronco. Your work spans the past, enriches the present, and offers visionary ideas for the future of critical care nephrology. That's probably why we have titled today's show as Critical Care Nephrology Past, Present, and Future. Let's embark on this journey by looking back. Professor Dr. Ronco, could you please share with us the key factors and healthcare needs that led to the emergence of critical care nephrology as a distinct specialty within medicine? Professor Dr. Ronco.
Well, thank you very much. First of all, I must say that I have recently visited India, Hyderabad in particular, and I had the opportunity to meet Dr. Tapas Kumar Sahu, and he mentioned about the Nephrocritical Care Society as an entity that includes several members, both from the nephrological and the critical care community. So I have to congratulate for having put together this kind of entity, which I think can represent a very important base for sharing information and establishing new standards and new operations, including new studies. So my best regards. And I have to tell you that I was so impressed that I have asked Dr. Tapas to present the Nephrocritical Society at the opening ceremony of the Vicenza course on AKI and CRRT this year in June in Vicenza, from 11 to 13 of June. And I think it would be very important to share the experience and to make all the audience aware about this entity. Also, I think that the structure of this society with periodic meetings in virtual modality or even in person if possible is a perfect condition to have especially young fellows and young investigators to share their knowledge, their information, and also at the end to share the problems and the questions that are not resolved and what are the unmet clinical needs. From the unmet clinical needs, critical care nephrology was born more than 40 years ago when one of my first fellows, Professor Rinaldo Bellomo, came to visit me in Italy, and we shared the frustration of not being able to take care of critically ill patients with kidney problems in a more organized way. Until that moment, the presentation and the studies were mostly, let's say, specialty-oriented and organ-oriented rather than being comprehensive and interactive. So intensive care and nephrologists were two separate worlds. In most of the cases, the intensivist was calling the nephrologist at the last minute of the day when the patient was already in a very severe condition and the nephrologist could not do anything. At the same time, the nephrology, knowing this situation, was sending the last fellow at the last minute during the day. And the consequence of this approach was that mortality was very high and standard of care was very low. So Professor Bellomo and myself decided to write an editorial that came out in the early 90s entitled Critical Care Nephrology, The Time Has Come. And we have analyzed what were the conditions that so far had brought to a sharp separation between the two disciplines, while we also analyze what could be the opportunities and the important possibilities offered by a close collaboration. Historically, nephrology and intensive care were separated, education was separated, there was a mentality of us and them, and there was no collaboration or marginal collaboration. After this editorial, we started seeing in various hospitals in the world a new task force, mostly composed by a nephrologist and one intensivist, that planted the seed for this collaboration and started to decide to carefully watch and follow the patients in intensive care with the possibility to share and melt the competence of the nephrologist and the intensivist. By doing this, new studies on extracorporeal blood purification therapies, on approach to critical ill patient, to sepsis, started to emerge. And in particular, I would say that there is a special moment in the history of critical care nephrology, which is around the year 2000, when we published the paper in Lancet on the dose of continuous renal replacement therapy, the famous 35 milliliters per kilogram per hour. This paper was the result of a study that lasted 5 years in our department in Vicenza, Italy. But we must say that originally there was a significant underdialysis to patients due to the fact that we had used continuous arteriovenous hemofiltration with no pumps, because in intensive care nobody wanted to have a blood pump. And subsequently, there was an evolution in the technology that led to the first and second generation of CRRT machines, in particular the development of the Prisma machine. That was the first machine designed to be applied for continuous renal replacement therapy in intensive care. One of the typical characteristics was the self-loading of the line, the auto-priming, and the limitation of the filtration fraction, avoiding unnecessary high filtration rates and coagulation of the filter. I think that after the year 2000, which is the same year in which we founded the ADQI Consensus Group Initiative, Acute Disease Quality Initiative, we started really a strong collaboration between intensive care and nephrology, and the two disciplines started to be much more integrated with the enormous amount of studies that were published in the last 20 to 25 years ago.
Thank you, Professor Dr. Ronco, for taking us through the incredible journey that has elevated critical care nephrology from a nascent idea to the esteemed super specialty it is today. Your passion and dedication are truly inspiring, highlighting the remarkable trajectory this field has undergone from its inception to the present status. Focusing on the current landscape, would you please share your insights on how critical care nephrology has evolved over the last 2 to 3 decades? Additionally, how has the integration of nephrology expertise within the intensive care units contributed to improving the outcomes of critically ill patients?
I think that we moved from the initial group of pioneers to a much larger audience and platform of investigators that have started from the initial ADKI meeting consensus on continuous renal replacement therapies, moving forward from the original skepticism concerning continuous renal replacement therapy and finally accepting this therapy as a standard of care in intensive care. More than that, the evolution of technology, including machines, devices, and understanding of new membranes and new mechanisms, certainly helped to optimize the therapy. With this, there was also an improvement in the monitoring device and the possibility to create a standardized prescription in terms of dose, frequency, duration, anticoagulation, and etc. The further step was when we started to consider extracorporeal blood purification therapy with the concept of multiple organ support therapy. We understood that blood could be the, let's say, substrate for specific therapies that go beyond the renal replacement and renal support and may help to improve clinical conditions such as heart failure, for example, modulating ultrafiltration and using hemofiltration to rebalance electrolytes and acid base. Using, for example, ECMO or ECHO, extracorporeal CO2 removal in patients that can therefore be ventilated mechanically with a very, very low tidal volume and a very, very good, let's say, tolerance to this therapy, what has been called ultra-protective mechanical ventilation. Plus, we have added different forms of filtration and absorption in patients that required blood purification in case of acute liver failure or acute and chronic liver failure. Or finally, we have explored the possibility to utilize extracorporeal blood purification therapies in sepsis and cytokine release syndrome. And I think that this represents the new frontier for the application of absorption that is probably the most recent advance in extracorporeal therapies. In parallel, we have seen a development of extracorporeal therapies for neonates and pediatric patients. And I think that this was a major advance because until a certain point, only PD was utilized, and these patients, small patients and babies, were suffering from what we call a orphan disease, which is AKI and sepsis in neonates and children. At this point today, we have the challenge probably to demonstrate beyond the efficacy of the new therapies such as hemoabsorption to increase the level of evidence. However, I would like to remind that evidence is not only provided by randomized controlled trials, and survival is not the only endpoints that we should study. In a critically ill patient, we might have other endpoints that move from biochemical endpoints, for example, looking at the behavior of specific molecules, to biological endpoints, looking at the behavior of monocytes and human cells and tissues in response to the therapy. And then we might have physiological and pathophysiological endpoints, including vital parameters such as blood pressure, ventilation, etc. And we may also include in the analysis of the endpoints some aspects related to disease severity, SOFA score, severity score, organ dysfunction, etc. In this case, I think it would be interesting to design trials not only as rescue therapies, but also as therapies that may prevent the worsening of organ dysfunction and the evolution of the syndrome. In typical cases like cytokine release syndrome, and we learned the lesson from COVID and sepsis and CAR-T therapy and other conditions. The blockade of cytokines may represent the answer to this, let's say, need to blockade progression of the disease. So I think that we have made a long way in the last 2 decades, but we have more studies to be done. We have just to make sure that we don't want to focus only and exclusively on survival and reduction of costs. We have to arrive to that endpoint, but the pathway towards that endpoint is long, and probably we need to go step by step.
That was impressive, Dr. Ramku. Rightly said. Recognizing the journey ahead is long and filled with potential. And this is the insight that led to the formation of Nephrological Care Society 1 year back, aiming to foster collaboration across multiple allied specialties, countries, and various societies. This initiative stands as a testament to the foundational work you and other pioneers initiated 30 long years ago. As we approach to the end of our discussion, my final question would be, do you believe that Nephrological Care Society should be an essential domain of learning for all critical care practitioners? Furthermore, how can we ensure a uniform standard of care in nephrological care globally?
I think that having a society probably represents an excellent starting point to gather experts, but also beginners of this type of science that may want to confront with people that have longer experience or wider possibility to see a large number of patients in big institutions and hospitals. The other opportunity today is offered by the internet connection and the possibility to meet virtually. Although, let me tell you, nothing substitutes the personal interaction. And this is the reason why I strongly recommend people to attend the meeting in person, because they have the possibility to confront with other colleagues that may have the same problem, or with experts that have already solved those problems. This is probably the secret to make sure that critical care nephrology is operated and implemented with the minimum standard of care that ensure a program of quality assurance that will be continuously improved by a continuous quality improvement strategy made of new acquisitions, new technologies, new information, and sharing of the information among the different members. I think we have today unique opportunities to make sure that we have a specific standard met because we can read publications, we can have information, we can ask the experts. With this, I think it is very important. I'm very happy that I had the opportunity to meet this Nephrological Care Society, because I really want to invite you all to attend our meeting, our course in Vicenza, Italy in June. And Dr. Tapas will circulate the save the date, and very soon we will circulate the program you will see from the program that we move from theoretical aspects of AKI to practical aspects of CRRT to direct hands-on sessions on machine or point-of-care ultrasound in order to go back with a suitcase full of information and of practical suggestions for your daily practice. One important comment is don't be afraid. In the moment you start the quality control, you will find that you have a lot of mistakes in your practice. This is a common practice for all of us. When you measure things, you find the errors. But when you don't measure, you don't find anything. So quality control is a very important method to establish what are the mistakes we're making every day and ensuring possible that every day we reduce a little bit the number of mistakes we make. This is a process that takes time, but it's part of the armamentarium of a specialty like critical care nephrology today, where we mix theory, we mix pathophysiology, we mix monitoring, and we mix extracorporeal therapies in one single approach to the patient. Don't be afraid to ask questions. Nobody was born completely knowledgeable. Ask questions and make sure that if you make a mistake, which is possible, this mistake will never happen again tomorrow. Now, it's interesting that you have this type of virtual meetings because today, really today, February 6th, is exactly 10 years from when we started our small YouTube channel, Cappuccino with Claudio Ronco. My recommendation is please register to this YouTube channel because you will find information about the most recent paper, you will find information about the most recent course, the recent ADKI meeting, the consensus conference, several different aspects debated by experts all over the world. So you can register on the YouTube at the Cappuccino with Claudio Ronco, which is another way to stay together and jointly probably move forward to the next step of critical care nephrology, which should be optimizing therapy, reducing mortality, reducing costs, and making therapy affordable to every patient. To see all of you in Vicenza.
Thank you, Professor Dr. Ronco, for so eloquently narrating the past, the present, and future of nephrocritical care. It's a treat to listen to you. Your insights have made it clear that this field encompasses numerous aspects, including therapy optimization, focusing on outcomes beyond just mortality, ensuring cost effectiveness, and advocating for a uniform, evidence-based approach worldwide. On behalf of the Nephrocritical Care Society and its 1,500 plus members, I extend our profound gratitude for sharing your valuable time and vision with us. Your contribution continue to inspire and guide our journey in critical care nephrology. Simultaneously, a heartfelt thanks to you all our listeners for joining today. Stay tuned for more enlightening conversations in our upcoming Straight Talk series with stalwarts of critical care nephrology. Thank you all.